Kieran here from Flex Physiotherapy, and I thought I'd just do a short video today on meniscal tears of the knee, or cartilage tears of the knee. It's quite a common injury. You may well have had a meniscal tear yourself, or a member of your family or one of your friends. You may have had an arthroscopy, which is a keyhole operation for a meniscal tear. It's quite common. It's quite a controversial subject at the moment, because our thinking around how best we manage these tears has changed quite a lot in the last few years. So I'm going to give you a bit of a background. I'm going to talk about acute tears versus more degenerate tears, and the appropriate management strategies for both types of tears. Okay, so if we kick off by asking, well, what is a meniscus? Well, a meniscus is a horseshoe-shaped piece of cartilage that sits in the knee. So I've got a knee here. So if we open the knee up, you can see. So you've got a horseshoe shape here and a horseshoe shape here. And both of these cartilages, these menisci, are adhered down to the surface of the tibia or the shin bone. Now, the function of the meniscus is twofold, really. The first is to improve the congruency of the joint, or the smooth running of the joint. So if you look there, you can see that the menisci form like little saucers for the femur to sit in, and that helps with the smooth flexion and extension of the knee. Okay, so that's the first function of the meniscus. The second function of the meniscus is to act as a shock absorber, and I think that's probably what most people think of when they think of the function of the meniscus, as a shock absorber. Now, each of these menisci, the way the menisci is formed, they have concentric bands of collagen fibres that make up the meniscus. Okay, so the meniscus itself has these bands of collagen fibres arranged in bundles that form these concentric rings around the meniscus. Okay. Now, the reason the meniscus is arranged like that is when you load the femur down through the meniscus then dissipates that downward force along the lines of these bundles, okay, circumferentially around the meniscus. Okay. And that's termed hoop stresses. So the meniscus is able to do that by utilising these hoop stresses to dissipate the force around the meniscus. Okay, so it's quite a clever function. And the reason that's important is that different meniscal tears affect the hoop stresses in different ways. So, for example, a radial tear is where you have a tear which comes up through the meniscus this way, okay, through the body of the meniscus. Okay. Now, a large radial tear will therefore disrupt the hoop stress mechanism quite significantly, which can lead to the meniscus being really biomechanically compromised. So a big radial tear can have quite a devastating effect on meniscal function. Another type of tear you can get with acute tears, these tend to be traumatic tears, is you can get a root tear, which is a root is on either side of the meniscus, where the meniscus is kind of attached down onto the plateau, onto the tibial plateau of the tibia. You can get a tear through the attachment. Okay, so the meniscus is no longer firmly adhered down to the tibia. Now, what can happen then is when you start loading through the meniscus, then the meniscus can actually extrude out of the joint. Okay. And if the meniscus extrudes out of the joint, clearly it's not functioning particularly well. But the other thing is that you've got some bone-on-bone contact, so the meniscus is not doing its job properly. And we know that the more bone-on-bone contact you have over time, what can happen is that you can develop some degenerative changes to the joint surfaces. Okay, so an extruding meniscus is not a good thing. Another acute injury which is quite common is a flap tear. Okay, so again you've got your meniscus, and you can have a piece of meniscus tear and it can flap around inside the joint. Okay, now flap tears can cause all sorts of problems. They can cause clicking, catching, locking of the joint, giving way of the joint. So flap tears can be quite disabling. We term those sorts of symptoms mechanical symptoms, and acute tears typically have mechanical symptoms. So if you have a history of trauma, so maybe you've had a dodgy tackle on the football pitch or something, you have a history of trauma, and you've got these mechanical symptoms, so the knees clicking, locking, catching. Actually, probably a physiotherapist is not the person to be seeing. You probably want to be seeing and talking to an orthopaedic surgeon who can actually remove that flap tear or that piece of cartilage which is causing problems within the knee. This is particularly true if you're quite a young person, so if you're kind of under the age of 30 or so. What can happen is that, well, it depends where the tear is. So the outside of the meniscus tends to be quite vascular, but as you move further into the meniscus, it tends to have a poorer blood supply to no blood supply at all. So if you have a tear in the meniscus in an area of the meniscus where there's a good blood supply, if you are young and the tear is in the right place, then it may well be repairable. And a repairable tear is obviously preferable to having a big chunk of meniscus taken out of your knee. So if you're a young patient, you've got a history of trauma and you've got mechanical symptoms, then I would really say you really want to be seeing an orthopaedic knee specialist sooner rather than later. Obviously, if you have mechanical symptoms and you end up losing a piece of cartilage via an operation, it's not, in the long term, it's not great for the health of the knee, but obviously it will help the knee to function a little bit better and help you get back to doing the things that you want to do. Now, a degenerate tear is different. Okay, so a degenerate tear typically is non-traumatic, so you don't have a specific injury, so it tends to be quite insidious. So you tend to get this kind of grumbling knee pain that develops with these degenerate tears. The degenerate tears tend to be horizontal tears through the meniscus, so turn the meniscus on its side. They tend to be horizontal tears through the meniscus. You can get complex tears where you have tears in different directions, and you can get some cysts associated with the meniscus as well. They tend to be more degenerate tears. Now, the thing about degenerate tears is that they're quite normal. So if you took a group of people over the age of, say, 35, 40, and you put them through an MRI scanner, the chances are that some of those people would have evidence of degenerate tears to their menisci, and they may not know anything about it. So it's quite normal, and indeed some people would say that degenerate meniscal tears are on the spectrum of osteoarthritis, so it's kind of one in the same process. So a degenerate tear may simply represent an early osteoarthritic knee, which may in time progress. So that's degenerate tears. Now, degenerate tears, the management of degenerative tears has become quite controversial over the last few years by virtue of the research that's come out on this subject. Now, there was one particular study which was done in 2013 now where a group of patients with degenerative meniscal tears was split into two groups, and one of those groups had arthroscopic keyhole surgery, so part of their meniscus was taken away. The other group, they had a couple of nicks put in their knee and they were put to sleep, and then they woke up and they didn't know, these two groups didn't know whether they'd had surgery or not. And the findings of the study were that there was no significant difference in the pain and function of those patients post-operatively. Okay, so they did exactly the same, whether they'd had surgery or not. So, and clearly the group that had surgery had the added disadvantage of having lost some meniscus from their knee. Arthroscopic surgery doesn't seem to be any better than sham arthroscopic surgery for this degenerative meniscal group. Okay, so that's quite important. The other thing to bear in mind is that we know that exercise-based rehabilitation for this group performs just as well as arthroscopic surgery. So if you were to have some exercise-based rehabilitation, meaning if you were to rehabilitate and load the knee appropriately 2 or 3 times a week as a minimum over a 3 to 4 month period, the chances are you'll have just as good a result as you would have done if you'd have gone on to have an arthroscopy. And again, if you'd have had that arthroscopy, you would have had the added disadvantage of having lost meniscal tissue. Having said that, about a third of patients who go down the conservative route and try and rehab the knee, about a third of them don't do very well for some reason. And we don't know why, whether it's something to do with the type of tear, maybe their health beliefs around degenerative tears or meniscal tears generally needing surgery. We don't know, but about a third of them don't do very well. And there is some evidence to suggest that those patients actually do quite well with arthroscopic surgery. So that's obviously quite interesting as well. So the key message really is that with degenerate tears, you want to try and load the knee for a period of 3 or 4 months before you consider any sort of arthroscopic orthopedic surgery. Now, there was a document came out last year. This is a summary of it, and it's a consensus document, and it's been written by the European Society of Sports Traumatology, Knee Surgery and Arthroscopy. It's a very well researched document. So it's written by a group of knee surgeons essentially, and they've come up with this algorithm. Excuse my scribbles. I've obviously read it. And they've come up with this algorithm, and essentially it says that if you've got a non-traumatic knee injury, and clinically it appears to be a degenerative meniscal tear, then really we should be trying this 3 to 4 month period of loading exercise before we consider any sort of surgical intervention. So that's key. So just to summarise, if you've got an acute mechanical traumatic tear and you're struggling with mechanical symptoms of clunking, locking, those sorts of symptoms giving way, you probably need an orthopaedic opinion on that, particularly if you're a young patient. If you've got a more insidious, grumbly knee and you're over the age of 35, 40 or so, you probably want to try exercise-based rehabilitation, particularly if there's no mechanical symptoms associated with it. So I do hope that's been helpful to you. Hopefully somebody out there will have found that helpful. Please feel free to share this video, to tag your friends or family maybe if they've got problems with a meniscal injury. And also if you make some comments below, I'll be very happy to answer any questions. Okay, thanks a lot. Bye now.